Hi, welcome to the lesson on liver failure. The objectives for today's lesson are based on the QCC framework. Assessment. Identify physical assessment changes in the client in liver failure. Communication. Very important. Utilize SBAR format and information technology to support and communicate plan of care for clients in acute liver failure. Caring interventions. Identify social, cultural, economic factors that impact care. Clinical decision making. Identify and discuss nursing interventions appropriate for the client in acute or chronic liver failure. Teaching learning. Explain dietary changes including elimination of alcohol to families and significant others. Objectives continued. Collaboration. Describe collaborative management of a client in acute chronic liver failure. Managing care. Identify the nursing management of the client in acute or chronic liver failure. Let's talk about the anatomy of the liver. It is the largest internal organ. It is located in the right upper quadrant of the abdomen, below the diaphragm. It is divided into 4 lobes. The blood supply of the liver originates from the hepatic artery and the portal vein. The hepatic artery, oxygen-rich blood is available, and the portal vein, nutrient-rich blood is available. The functions of the liver are many and varied. There are over 500 functions that the liver participates in. This is just a partial list. Assimilating and storing fat-soluble vitamins, creating bile to emulsify fats, filtering blood, which is one of the most important functions, metabolizing fats, proteins, and carbohydrates, metabolizing hormones, internally produce waste and foreign chemicals, producing urea, a primary waste product flushed from the body and urine, purifying and clearing waste products, toxins, and drugs, storing important nutrients such as glycogen and glucose, vitamins and minerals, gluconeogenesis, which is the formation of new glucose, which also occurs to a minor degree in the intestines and kidneys, synthesizing blood proteins. One of the most important functions of the liver is conversion of ammonia. As mentioned previously, the process of gluconeogenesis occurs in the liver, which is the formation of new glucose. This process and the metabolism of protein creates ammonia, which the liver then converts into urea. And when this process is altered due to liver disease, we have retention of ammonia and change in mental status, which we will discuss further in this lecture. Intestinal ammonia is also removed by the portal blood for urea synthesis. Both of these actions are affected to a degree when the liver is not functioning appropriately. One of the most important functions for us to be concerned about as nurses of the liver is drug metabolism. Extensive conjugation of certain medications to form more soluble substances is called the first pass effect. These medications have a high extraction profile and are dependent on the blood flow through the liver for metabolism. Example of these drugs include lidocaine, verapamil, propranolol, and nitroglycerin. Decreased hepatic blood flow, extrahepatic and intrahepatic blood shunting, and loss of hepatocytes alter the ability to metabolize drugs. The bioavailability of these administered medications increases, effectively increasing the dose. Other functions of the liver include bile formation, which helps to emulsify or break down fats, bilirubin excretion. Bilirubin is produced by the liver and is excreted in the bile. Elevated levels of bilirubin often indicate an obstruction of bile flow or a defect in the processing of bile by the liver. When the liver is diseased, bilirubin is increased. The assessment of the patient in liver failure begins with an extensive look at the health history, particularly looking at the previous exposure of the patient to hepatic toxic substances or infectious agents. What is the history of alcohol and drug abuse? We know alcohol abuse places the patient at risk for liver failure. What is the medication history? Routine consumption of over-the-counter medications such as Tylenol places the patient at risk for liver failure. What is the history of psychological illnesses? We know psychological illnesses place the patient at risk for drug and alcohol abuse, which again contribute to liver failure. What is a familiar or genetic history? Does the patient have a genetic history of hemochromatosis, Wilson's disease, or alpha-1 antitrypsin disease? All of these place the patient at risk for liver failure. Continuing with our physical assessment of the patient in liver failure, we're looking at the skin mucosa and sclera for jaundice. Jaundice is a condition that causes the skin, eyes, and mucous membranes to become yellow. It's a disorder that results from high levels of bilirubin in the blood. The condition itself is not fatal, but is definitely a sign of extensive liver damage, which we know can be life-threatening. The extremities are assessed for muscle atrophy, edema, skin excoriation, secondary to scratching. Again, high levels of bilirubin causes itchiness in the skin. We are looking at the skin for petechiae or ecchymotic areas, spider angiomas, and palmar erythema. We know the patient in liver failure is at risk for bleeding due to the alteration in blood coagulation proteins. The male patient is assessed for gynecomastia and testicular atrophy due to hormonal changes. Cognitive status is also assessed. Memory, abstract thinking, and neurological status is also assessed. General tremors, asteristics, which is flapping of the hands, weakness, and slurred speech is assessed. We're looking at the abdomen, checking for a fluid wave. The abdomen is generally distended, filled with fluid, different than distension that occurs from obesity. That's why, in this case, we actually check for a fluid wave, which is actually causing fluid to flow from one side of the abdomen to the other. This is a picture assessing for an abdominal fluid wave. The practitioner is making the fluid move from one side of the abdomen to the other, which is what occurs in liver failure. You would be unable to do this on a patient who is not in liver failure. An important lab test to look at is bilirubin, both total serum bilirubin and urine bilirubin. Bilirubin is produced when the liver breaks down old red blood cells. Conjugated or attached bilirubin is called direct bilirubin, and this is metabolized by the liver. Unconjugated bilirubin is called indirect bilirubin, not metabolized by the liver. Results are abnormal or elevated in liver and biliary disease. Elevated unconjugated or indirect bilirubin rarely reflects liver disease and is commonly found in hemolytic disease, hemolytic anemia, for example. Elevated conjugated or direct bilirubin almost always reflects hepatobiliary disease. Elevated delta bilirubin reflects hepatobiliary disease and remains elevated longer than other bilirubin fractions during the convalescent phase of liver disease. Any bilirubin found in the urine is the water-soluble conjugated fraction and implies hepatobiliary disease and is associated with jaundice clinically. So the most important thing for you to remember from all of this is that direct bilirubin is elevated in liver disease, reflected by jaundice clinically, and is something we need to look at for the patient in liver failure. Other important lab tests specific for liver failure or the patient in liver failure are LFTs, SGOT, SGPT, GGT, LDH. SGOT and SGPT are specific for liver disease. GGT is elevated with the patient who has alcohol abuse. It also can be a marker for gallstones. LDH is elevated in alcohol abuse and is also a marker for gallstones. And the normal ranges are listed on this slide. Still, other important lab tests for the patient in liver failure include serum protein, serum albumin, serum globulin. Protein is manufactured by the liver. Levels may be affected in a variety of liver impairments. The albumin-globulin ratio is reversed and showing decreased albumin and increased globulin with the patient in liver failure. Your prothrombin times may be prolonged, your PTT times may be prolonged, cholesterol is elevated in biliary obstruction and decreased in liver disease. So the person who is in true liver failure no longer needs those cholesterol-lowering medications, which are actually toxic to the liver in the long term. Just some statistics with regards to liver failure. The number of discharges with liver failure or cirrhosis as the first listed diagnosis is 101,000 based on 2010 data from the CDC. Mortality rate, the number of deaths from liver failure is 31,903. Deaths per 100,000 population is 10.3. So what are the causes of liver failure? First of all, liver failure results from the damage to the liver's parenchymal cells. Causes include trauma, alcohol abuse, infections such as hepatitis A, B, C, D, autoimmune causes. Liver failure is more common in men than women and more common in blacks than whites. Fatty liver disease is a reversible condition where its large vacuoles or cells of triglycerides accumulate in the liver cells via the process of steatosis, abnormal retention of lipids within a cell. Despite having multiple causes, fatty liver can be considered a single disease that occurs worldwide in those either with excessive alcohol intake or the obese. The liver cells respond to the most noxious agents by replacing glycogen with lipids. Chronic disease causes the liver to become fibrotic with diminished function. Cell regeneration can occur if the disease is not too advanced. This is a slide talking about non-alcoholic fatty liver disease. This is a term used to describe the accumulation of fat in the liver of people who drink little or no alcohol. Non-alcoholic fatty liver disease is common and for most people causes no signs and symptoms and little complications. But in some people, the fat that accumulates can cause inflammation and scarring in the liver. The more serious form of non-alcoholic fatty liver disease is sometimes called non-alcoholic steatohepatitis. At its most severe, non-alcoholic fatty liver disease can progress to liver failure. So what are some consequences of liver failure? As discussed earlier, jaundice occurs from increased bilirubin in the blood. And again, that means the skin is turning yellow, the sclera of the eyes are turning yellow, and these are the areas that you would most likely see jaundice in. Portal hypertension from circulatory changes in the liver causing ascites, which is that large fluid-filled abdomen, and varices, outpouching of the veins can cause bleeding, particularly in esophageal varices if the veins burst. Hepatic encephalopathy from increased ammonia from impaired protein breakdown, another important consequence of liver failure. Now let's talk about liver failure. What is liver failure? The inability of the liver to perform its normal functions. Just to refresh your memory, some of these normal functions include detoxification, gluconeogenesis, coagulation, the formation of new blood proteins. Acute liver failure differs from chronic liver failure. In acute liver failure, there is generally the development of a hepatic encephalopathy, confusion, stupor, and coma, and decreased production of proteins such as albumin and blood clotting proteins within 4 weeks of the first symptoms, such as jaundice. Chronic liver failure is progressive, happens over a longer period of time. Some causes of chronic liver failure include cirrhosis and non-alcoholic fatty liver disease. Question: which of the following is not considered an age-related change of the hepatobiliary system? Decreased drug metabolism, increased blood flow, decreased liver weight, increased prevalence of gallstones. Think about it. Now let's talk about hepatic encephalopathy and coma. This is a life-threatening complication of liver disease. Occurs with profound liver failure, usually from the accumulation of ammonia. Portal system encephalopathy is the most common mechanism. The survival rate after a first episode of overt hepatic encephalopathy in patients with cirrhosis is approximately 40% at 1 year. So as you can see, liver failure carries a high mortality rate with it. Just a little bit about the pathophysiology of hepatic encephalopathy and coma related to liver failure. The liver cells are not working properly, so they fail to detoxify and convert the ammonia to urea, a very important process. So as the ammonia continues to rise, it enters the bloodstream. The increased serum ammonia tends to aggravate or precipitate the hepatic encephalopathy. So what are some sources of this increased ammonia? Enzymatic and bacterial digestion of dietary and blood proteins in the GI tract. GI bleeding, a high-protein diet, bacterial infection or uremia, another cause. Alkalosis or hypokalemia, yet another cause. Excessive diuresis, dehydration, infections, surgery, EVA, and some medications that cause potassium loss. Ammonia is decreased by elimination of protein from the diet and use of antibiotic agents such as neomycin and use of lactulose. Now let's discuss the clinical manifestations of hepatic encephalopathy. Some of the early changes include some mental status changes and motor disturbances. Patient might appear slightly confused, unkempt appearance. There might be some alterations in mood and sleep patterns. Asteristics develops, which is a flapping or tremor of the hands. Simple tasks may become difficult. Constructional apraxia might develop, which is the inability to perform coordinated complex movements. Deep tendon reflexes are hyperactive early on, and with the worsening of the encephalopathy, the reflexes may disappear altogether and the extremities may become flaccid. Some late stages of hepatic encephalopathy include possible loss of consciousness, or at least completely disoriented with respect to time and place, and late stages are coma and seizures. This is just a slide showing asteristic, that flapping tremor of the hands that occurs with hepatic encephalopathy. Now let's talk about the management of hepatic encephalopathy. First, we need to identify and eliminate any precipitating cause if it's known. Lactulose is administered to reduce serum ammonia level, and generally this is administered more than once or twice a day. 2 or 3 soft stools per day are desirable. If the patient starts to develop diarrhea, this indicates that there has been a medication overdose. Lactulose may be administered by nasogastric tube, enema, or IV. Glucose can be administered to minimize protein breakdown. Administration of vitamins is often necessary. Correction of electrolyte imbalances, particularly potassium, are very important. The discontinuation of sedatives, tranquilizers, and analgesic medications occurs. Benzodiazepine antagonists, such as romazican, may need to be administered in these patients to prevent sedation from previously taken benzodiazepines. So what is portal hypertension? Simply, it is obstructed blood flow through the damaged liver, which results in an increased pressure throughout the portal venous system, an important mechanism in the development of ascites. Some other common manifestations include splenomegaly, varices, and dilated abdominal veins and hemorrhoids. This is just a slide depicting the physiology or pathophysiology in the manifestation of esophageal varices, which is an important complication of liver failure which carries a high mortality rate. Basically, abnormal vessels develop and enlarge in the esophagus and can potentially rupture due to the high pressure, which of course would cause massive bleeding in the patient. Let's talk a little more in depth about esophageal varices. Varicosities develop from elevated pressure in the veins that drain into the portal system, and these varicosities are prone to rupture. Some factors that contribute to hemorrhage are muscular exertion, straining at stool, sneezing, coughing or vomiting, esophagitis, reflux of stomach contents, salicylates, or any anticoagulants for that matter. Clinical manifestations include hemaemesis, melena, general deterioration in mental or physical status, often has a history of alcohol abuse, and signs and symptoms of shock, since this is actually a hypovolemic shock that occurs as a result of this manifestation of bleeding. Cool, clammy skin, hypotension, and tachycardia are some signs of shock, just as a review. Medical management of ruptured esophageal varices includes balloon tamponade with Ascension Blakemore tube, a Minnesota sump tube, and some medications include vasopressin, Inderal, and Corgard, surgical and endoscopic treatment, and possible transfusions. The tubes just mentioned are basically large NG tubes that actually put pressure on the varices to prevent further bleeding. Further medical management includes endoscopic therapies with sclerosing agents, which are injected through fiber optic endoscope into the bleeding esophageal varices, so they basically sclerose the vessels to prevent further bleeding. Esophageal banding therapy and transjugular intrahepatic portal systemic shunting, or a TIPS procedure, is also a possible option. This is just a picture depicting the TIPS procedure just mentioned. This is a picture depicting balloon tamponade, which puts pressure on the bleeding vessels to prevent the patient from bleeding out. Nursing management of the patient with esophageal varices includes monitoring vital signs, assessing cognitive status, general full assessment, nutritional and neurological status, assessing for signs and symptoms of encephalopathy. Parenteral nutrition most likely will be indicated, since the gut will not be able to be used due to the recent injury associated with the bleeding. Gastric suction, oral hygiene, and moist sponges to the lips. Vitamin K therapy, possible blood transfusions, low stress environment, calm reassurance. Possible delirium management might be indicated, since these patients generally have an alcoholic background in their history. End-stage liver disease, fifth leading cause of premature death nationwide. These are 2008 statistics, and this is related to alcohol. Some other causes of liver failure include chronic hepatitis B or C, drugs, infections, obstruction of bile, and progression of non-alcoholic fatty liver disease. A little bit about the pathophysiology of hepatic cirrhosis. Primary cause is alcohol consumption. Nutritional deficiency with reduced protein intake occurs. These patients are generally malnourished because they get all their calories from the alcohol, not from food. Exposure to certain chemicals can cause cirrhosis of the liver. Increase in males between age 40 and 60 years of age. Alcohol cirrhosis is characterized by episodes of necrosis involving the liver cells. Infiltration of hepatocytes with lymphocytes and leukocytes produces necrosis fibrosis. Accumulation of fatty cells, or fatty liver, as we've been discussing. Fatty livers have an increased incidence of liver cancer. Cell necrosis, destroyed cells are replaced by scar tissue. The cirrhotic liver has a characteristic hobnail appearance, insidious onset, and it has a long, complicated course. Some clinical manifestations of cirrhosis include edema, which is a late sign, reduced albumin, overproduction of aldosterone. Portal obstruction and ascites occurs, caused by the liver failure and obstruction of the portal circulation. Hypotension, spontaneous bruising, vascular spiders, pruritus, just some of the manifestations of hepatic cirrhosis. Some other manifestations include vitamin deficiencies, anemia, fatigue, sparse body hair, white nails, peripheral neuropathy, mental deterioration, intermittent jaundice and fever, muscle wasting, weight loss. This is just a picture of a patient with ascites. Notice the large abdomen and some surgical scars on the abdomen as well. This is just a picture depicting jaundice. Notice the very yellow skin of the client laying in bed. Some clinical manifestations associated with liver failure that we've been discussing all along include ascites, which is increasing abdominal girth and rapid weight gain, and hepatocellular jaundice, caused by the inability of damaged liver cells to clear normal amounts of bilirubin from the blood. Some other clinical manifestations of liver failure include the hepatorenal syndrome. This is actually a cause of renal failure. Ascites decreases the glomerular filtration rate. The renin-angiotensin system is activated, causing sodium retention. Excess nitrous weights, called azotemia, increase, and eventually oliguria occurs. Some tests used to evaluate the client or patient in liver failure include ultrasound, MRIs and CAT scans, radioisotope liver scans, laparoscopic procedures, ERCP, and you could read the different definitions of these tests on the slide. Some other diagnostic tests used to evaluate and manage the patient in liver failure include the percutaneous transhepatic cholangiography. This is when dye is injected via the skin to the liver to assess the liver. Complications include bleeding. Liver biopsy to determine the scope of liver disease. Complications include bleeding and bile peritonitis. Methods include percutaneous liver biopsies, transvenous, and laparoscopic. Post-procedure, the patient should be positioned on his or her right side, avoid coughing and or straining. And when the patient is discharged, instructions should include to avoid heavy lifting times 1 week. Medical management of the patient in liver failure with ascites includes dietary modification, low-salt diet. Diuretics may be administered. Paracentesis, which is a removal of fluid from the abdominal cavity to facilitate ease of breathing. IV salt poralbumin might be administered at the time that a paracentesis is performed to manage the blood pressure. Transjugular intrahepatic portosystemic shunt, which is a TIPS procedure. A stent is inserted via a catheter to the portal vein to divert blood flow and reduce portal hypertension. A periovenous shunt might be placed to redirect fluid from ascites from the peritoneal cavity into the systemic circulation. Very rare that this procedure is done. Paracentesis. First, you want to explain the procedure and its purpose to the patient. So what is the procedure? The procedure is placing a large needle into the abdomen to facilitate removal of fluid that has accumulated in relation to liver failure. So think about the potential risks and complications to this procedure. Have the patient void before a paracentesis, because one of the risks or complications of this procedure is puncturing the bladder. Support and maintain the position of the patient during the procedure to avoid the complication of bleeding. Record both the amount and the character of the fluid aspirated. You could take out as much as 2 or 3 liters. However, this might cause the patient to have a dramatic drop in their blood pressure, thus necessitating the infusion of salt poralbumin at that time. Observe for evidence of coughing, increased dyspnea, or pulse rate. Hopefully, nothing else got punctured during the procedure. So what does the nursing management of ascites include? Eyes and nose, daily weights, measurement of abdominal girth, monitoring of serum ammonia and electrolyte levels, skin care, identify early signs and symptoms of complications such as encephalopathy, spontaneous bacterial peritonitis, dehydration, electrolyte abnormalities, azotemia, teaching regarding avoiding nonsteroidal anti-inflammatory agents, medications. Example, cough mixtures containing alcohol, antibiotics, or antacids containing salt when the patient is DC'd. Other complications of the patient in liver failure include the hepatorenal syndrome, which is often caused by GI bleed, a paracentesis, diuretic therapy. You would assess the patient for azotemia, increase in nitrogenous waste, oliguria, decrease in urine output below 30 cc's an hour. Intractable ascites. This means ascites, no matter what the management is, still continues to reoccur. Management for the complication of hepatorenal syndrome would include a renal consult, monitoring labs, particularly BUN, creatinine, and potassium, monitoring your urine output. If no urine output in 24 hours and potassium is 7, this patient might require hemodialysis. Nutrition and liver disease. Limiting protein intake in liver disease to 1 to 1.5 grams per kilogram is an important consideration because it decreases the work of the liver. Calorie requirement is about 25 to 35 calories per kilogram. No carb or fat restriction because this doesn't complicate liver failure despite impaired metabolism. Elimination of alcohol is key. Limiting sodium to 1,500 to 2,000 milligrams per day is extremely helpful. The patient may need to be on a fluid restriction of 1,000 to 1,500 mLs per day. Vitamin and mineral supplements, especially fat-soluble vitamins, are going to be required. Small, frequent meals because the patient wouldn't be able to tolerate a large meal. Avoid spicy, coarse foods, particularly with esophageal varices. Enteral feeding as needed or TPN as needed, particularly with the patient with the complication of esophageal varices. Even though the liver does regenerate, it is often not enough to regain full functioning once the liver is in complete failure. So one of the most hopeful alternatives for the patient in liver failure is to get a transplant. This can either be obtained from a Godiva living donor. It can be a whole or a portion of the liver. The most important thing for the patient to understand is that they must be maintained on immunosuppressants for life. Some examples of these immunosuppressants include cyclosporine or prednisone. Nursing management of the patient after transplant includes a daily assessment of mental status, lungs, abdominal girth, a full head-to-toe assessment, checking for peripheral edema, monitoring labs, reporting abnormalities. Fluid and sodium restrictions are still maintained initially, maintaining bed rest, understanding that the urine will be dark and monitoring eyes and nose, monitoring vital signs including O2 sat. Now we're going to switch gears a little bit and speak about the indications for transfusion. These include a low hemoglobin and hematocrit. Different institutions will have different regulations about when is it appropriate to transfuse a patient. So you must remember your norms. Female hemoglobin 12 to 15%, male 13 to 17%, female hematocrit 35 to 46%, male 41 to 50%. Now this is just taken from one lab's reference range. There are different reference ranges in different institutions, and you must follow that when looking at transfusion guidelines. A second indication for transfusion is obviously active bleeding, and the third indication would be hypovolemia and/or shock, again related to active bleeding. Some blood and blood components that are commonly used in transfusions include whole blood, although we don't see that much in practice anymore, packed RBCs, platelets, fresh frozen plasma, and albumin. Some important considerations to be mindful of during the transfusion procedure include checking your order, of course. This is different though. 2 RNs must check the transfusion order and the slips to avoid complications of giving the wrong blood to the wrong patient. Check the type and cross-match. Fresh frozen plasma needs an ABO slip, which is a blood typing slip. Platelets don't need an ABO or an RH slip. Verify consent. Explain to the patient what's going to happen. Baseline vital signs should be taken, and then 15 minutes later, another set of vital signs to be taken, because the reaction that the patient might have is most likely to occur within the first 15 minutes. A large bore needle and a separate line should be utilized for blood transfusions. I know this is not always possible. The blood should be initiated within 30 minutes from when received, and it should finish within 4 hours to avoid bacterial contamination. Why tubing is used? It means one side of the tube has normal saline on it and the other side has the blood transfusion on it. The tubing should be changed every second unit to again avoid bacterial contamination. The patient should be monitored for transfusion reactions, monitored for hives, itching, nausea, shortness of breath, fever, chills, and back pain. This transfusion should be stopped immediately and the line flushed with normal saline. The blood should be returned to the lab for examination. A urine should be obtained post-procedure. These are some potential nursing diagnoses to think about when caring for the patient in liver failure. Risk for impaired gas exchange, risk for fluid overload, altered thought process, risk for impaired skin integrity, risk for injury. Think about the assessments that go along with all these potential nursing diagnoses. The interventions are listed on this slide for you to review. This concludes the lecture on liver failure. I hope it has been helpful in explaining some of the concepts when caring for the patient in liver failure.